Hi, I'm Kathy Harrington. I'm an associate professor in the School of Medicine in the Pulmonary Division, and I'm going to talk today about health behavior research. So, what is the study of health behavior? Well, it's the study of the determinants and outcomes of behaviors that affect health. So why do we do this? Well, we do it for three reasons. One is we want to explain behavior, we'd like to predict behavior, and we want to change behavior. So, for instance, we might want to know, why are people overweight? What puts someone at risk for being overweight? And what will help somebody to reduce their weight? So why do we study health behaviors? Well, there's a couple of reasons. One is it's a public health problem that we want to examine, and we want to know, what's the behavioral cause? What are the correlates of these causes, or what things are associated with it? That helps us know what we might be able to change. And we want to identify the ways to change this behavior, and we want to know the context in which we can make those changes. So that we do this, that is, change behavior that's related to health with theory-driven interventions. So we also study health behaviors for clinical health problems. So we want to know ways that we can change behavior that might cause or exacerbate a disease. And we want to know ways to promote healthy behaviors. In other words, think prevention. So I mentioned before that we do health behavior examinations of causes and changes by using a health behavior theory. And so exactly what a theory is, well, it's a set of interrelated concepts, definitions, and propositions that present a systematic view of events or situations by specifying the relations among the variables in order to explain or predict the events or situations. So here's an example of a theory. This is the health behavior theory, and I chose this one because it's fairly simple and easy to understand. And when you're looking at this theory, most of the time we start, when we're reading something, we look at the left and work our way to the right. But in this case, I want you to start over here on the far right, with the behavior. Whatever the behavior is that we're interested in, we know that for someone to act, they have to intend to act, unless it's an accident. But we're thinking about behaviors that people have control over. So in other words, they have an intention. And we want to know, what is it that influences that intention? Well, there's two things. There's attitudes towards the behavior. In other words, what do they think about it? Do they think that this is going to give them a positive outcome? Is it going to give them a negative outcome? Is it going to be hard? Is it going to be easy? We call these things beliefs and evaluations of the behavioral outcomes. So I might believe that exercise is very difficult, and I might know that if I exercise, I'm actually going to feel better and maybe lose weight. So my attitude is, well, it's going to be hard, but it's going to have a really good impact on my life. So that's going to impact my intention. So whether or not I think it's harder is more important, or whether I think it's going to have a good impact is important. We'll decide whether I'm for it or against it. But the other thing that impacts my intention is my perceived norms. And that's based on my normative beliefs. That is, what do I think other people think is healthy and normal? So for instance, I'm going to use cigarette smoking because that's one of my favorite topics, and it's something that we all know a fair bit about. That with cigarette smoking, I think the majority of the population knows that cigarette smoking is bad for your health and bad for the people around you. But, so therefore, my perceived norms is, because everyone around me thinks that, I think that too. And most people think it's not polite to smoke in front of someone who doesn't smoke. So my norm is that you wouldn't smoke in front of other people, and you wouldn't expose other people to your smoke. But there are people who maybe have a different group of peers or different set of norms, and they don't believe that. So their attitudes or their perceived norms about smoking are going to be different than mine. And that will influence behavioral intention. And then that intention, in fact, goes to our behaviors. So we use these theories both to understand behaviors and predict them, as well as to change them. So there are a lot of theories, and these theories range everywhere from an ecological theory, which is multi-level, everything from the interpersonal to the interpersonal to the organizational community and public policy. Social marketing is a good example of that. Interpersonal, which is between two individuals, diffusion of innovations, social cognitive theory are a couple of examples of that. And then we have the intrapersonal, or the within the individual, stages of change, and the theory I just showed you, the health belief model. So we also have to think about all the factors that influence behavior, and there are quite a few. For instance, we know the environment impacts somebody's behavior. And by environment, we don't just mean their physical environment, but we also mean the circumstances, the objects, and the conditions in which they live, work, and play. Social cultural, that relates to or involves a combination of their societal and cultural factors. So for instance, they may have an ethnic background that has a particular culture that's not the mainstream American culture that might influence some of their behaviors. It might be where they live in society in terms of what their social circumstances are that impacts their behaviors. And then we have the psychosocial, and that's really kind of what's inside that relates to your psychological makeup along with your social aspects, or like, for instance, what your norms are, what you think other people believe is normal, healthy behavior, as well as your attitudes and beliefs about your own behavior. So again, as I mentioned before, we use health behavior research to explain and predict behavior. So one of the things we want to do is we want to identify the behavioral determinants of morbidities and mortalities. By this I mean injury, illness, death. So for instance, cardiovascular disease, we would think diet and exercise, smoking and stress. There are other factors, but these are the four sort of behavioral factors that we think most often about. Motor vehicle accidents. We might think about drinking and driving, speeding, or using technology, texting, all influence motor vehicle accidents, and these are all behaviors. And then diabetes. Right now, it's a big impact on our health in terms of type 2 diabetes that's caused by often by obesity, which is due to poor eating habits and lack of physical activity. So some of the things that we might do is in identifying the psychological and socioeconomic determinants of a health-related behavior. And I'm going to talk about smoking because I think it's easier to understand these concepts when you use a very concrete example. So when we think about smoking and we want to think about the psychological and socioeconomic determinants of smoking, we know that if we want someone to quit, one of the things we have to think about is how do they feel about their confidence? Do they feel confident that they can quit? Or have they tried before and failed, and so then they have what we call a lack of self-efficacy or a lack of confidence in their ability to quit? What are their perceived norms? Well, for an adolescent, if you ask them, they might say smoking is cool. Are they going to give up a cool behavior? Possibly not. You might take somebody who is in an environment where all of their friends smoke. You know, smoking is a social thing to do. Or you take somebody who maybe is the only person in their household who smokes, where they don't feel smoking is such a social thing. And what are their outcome expectations? Some people say that quitting smoking will make me gain weight. And if I'm concerned about my weight, I certainly don't want to quit smoking because I don't want the weight gain. Or I might have an outcome expectation that if I quit smoking, my breath is going to smell better and my teeth are going to look better, and that might convince me that I do want to quit smoking. And what are the barriers to quitting? Well, one barrier might be that all of my family smokes, and what am I going to do when everyone around me is smoking? Another barrier is that some people use smoking for a stress reliever. How am I going to relieve stress? How am I going to calm down when I'm upset if I can't have a cigarette? And then the perceived benefits. My teeth will look better, I'll feel better, I'll be healthier, maybe my spouse will quit nagging me, whatever it is. So for any individual, all of these factors might be things that would influence their ability to quit smoking. So we also think of health behavior research in terms of change. So what we do is we use the factors that we found were important in predicting and explaining the behavior, and we think about how we can influence these to change behavior. So we develop an intervention maybe that helps increase someone's confidence to quit smoking. We might help them see that not everyone thinks smoking is cool. We might help them understand and see some of the benefits of quitting, and we might help them figure out ways to overcome their barriers. For instance, maybe help them figure out a better stress reliever. So we develop an intervention. I'm going to use an example here that we actually did with some adolescent females to reduce sexually transmitted diseases. So once again, we develop an intervention. We use all of the factors that we know are related to the behavior. And two of the factors that we particularly wanted to work on were condom skills, in other words, how to use a condom properly, and self-efficacy, in other words, confidence, for partner communication. So we did training to teach them how to do proper condom application, and we gave them chances to role play. We modeled communication, and then they got a chance to role play, and we gave them feedback on how to talk to their partner about using a condom. So then what we wanted to do is we wanted them to use condoms during sex. In other words, safer sex. So that was the behavior change we were after. And the outcome, the health outcome we were interested in, was a reduction in sexually transmitted infections. So another example would be with children that we wanted to teach them to use a peak flow meter to track their asthma. So we knew that to teach them how is we had to show them what a peak flow meter was. We had to show them how to use it. We had to let them practice using it. We had to correct it when they did it incorrectly and let them practice some more. And then we had to help them figure out ways to remember to use it. So the change we were after was that they would use the peak flow meter, and if they got a certain response from the meter, in other words, that they were not in the green zone, which is meaning normal breathing, but they were in the yellow or red zone, which meant that they were having difficulty breathing, that they would then use their asthma rescue medication to control their asthma symptoms and to reduce their problems with breathing, and that would keep them from having a full-blown asthma attack. Another example, how to teach somebody how to use a nutrition label. The new nutrition labels that came out about 10 years ago were kind of not often read by people, and people don't understand how to read them or what's important to them. So depending on what their dietary needs are, whether they need low sodium, they need to avoid carbohydrates, or they need to just reduce calories, we would teach them how to read the label. The behavior we're after was that they would make better choices in the grocery store based on whatever our goal was in terms of the nutrition label. So the health outcome might have been lower weight, which reduced the risk for diabetes, heart disease, skeletal problems, and some cancers, or it may have been specific to lowering blood pressure by reducing sodium, or it may have been for a diabetic to teach them not to eat a lot of carbs. So there are other forms of change that are part of health behavior research. So we can also develop social, political, or economic policies that positively change the determinants of behaviors that impact health. For instance, this is one we all are aware of, a political one, which is the seatbelt law. Now that came into effect over time, some time ago, but before we had a seatbelt law, we had very high level of traffic mortality and greater morbidity because people were just injured more in traffic accidents. So the first thing they did from a political standpoint was to have car manufacturers start requiring that they add seat belts when they built a car. And then we started having state laws that would fine people if they weren't wearing seat belts, and they also promoted signs, but those buckle up for safety signs that you see on the highway. And then that was part of the motivating passengers and drivers to use seat belts. So we know that what happened from that political move was we reduced traffic mortality and injury a good deal. So then another one, social, is indoor smoking bans. Well, now they're pretty common, but they're not everywhere. And we don't even have workplace smoking bans in some areas. It's improving. But what we found is that by having an indoor smoking ban, we reduced the exposure to secondhand smoke among non-smokers, and we actually reduced the rates of cancers. For instance, 11% of lung cancer and other cancers are a result of secondhand smoke. And then economic. So insurance pays for weight reduction counseling. And what happens is we now have weight reduction counseling more available to the people who need it at no out-of-pocket cost to them. So that's kind of why we do it and what it looks like, but how do we actually do it? So we need to talk about study designs. And quite honestly, health behavior research study design can look just like any other study. It can be cross-sectional, retrospective cohort follow-up, longitudinal matched control, pretty much anything. But again, the randomized controlled trial, which is the study design most people are familiar with. And this is an example of a behavioral randomized controlled trial. It looks just like the design for any other randomized trial. You recruit your participants, you give them a baseline exam measuring all of the things that you're interested in. In this case, it would be a behavior, possibly an outcome related to behavior. For instance, if we were interested in an obesity intervention, we might be measuring their weight and height and maybe waist circumference, and we would also be concerned about maybe their eating habits and their exercise habits. And then we give them, we randomize them to either an intervention where they get the behavioral intervention that we've designed using a theory-based intervention, or they get a control group, which when we talk about that from a behavioral standpoint, a control group to us is kind of nothing. They don't get anything. Whereas a comparison group is kind of like they get a placebo control. We give them the same amount of time and attention because we know that can change behaviors, but maybe on a topic that's unrelated to our outcome. And then we do follow-up exams. We might do one, we might do two, we might follow them every month for a year. It depends on what our outcome is and how soon we expect to see change and whether or not we want to track change over time. So here's an example, a public health problem we're all familiar with. So obesity, we know, is a risk factor for heart disease, many cancers, asthma, diabetes, mobility problems, and the list goes on. We know that obesity rates have been increasing. And I just saw a study that came out this week showing that it's increased even more, despite our best efforts. So what do we do about it? Well, our challenge is, what's causing it to increase? Well, we want to look at biologically plausible causes. So we know that higher calorie intake, less calorie output equals weight gain, and that leads to obesity. So then we want to think about, okay, that's pretty obvious. We know those are true. Let's think about some of the environmental, social, cultural, and psychological factors that might be correlated. Well, let's think about this for a minute. For the environment, how often do we walk? We don't. We live in a society now where we drive our cars pretty much everywhere we go. Let's think about the dinner plate. What size is an average dinner plate? Take a minute and think about how big your dinner plate is at home. I'm guessing it's somewhere around 10 or 11 inches across. Well, back in the 1960s, that same dinner plate was 7 to 8 inches. Well, we all have a tendency to fill up our dinner plates. Let's think about another environmental factor. How often do you eat out? And what control do you have over that food that you order in a restaurant? Do you even know what the ingredients are sometimes? One of the reasons I know it tastes so good is I know they add a lot of butter, which I like, but I also know it's not very good for my waistline. So we've had a lot of environmental changes over the years, which has led to this obesity epidemic that we're facing now. So, what can we do to change it? How can we reduce it? Well, we could change eating behaviors, and we could change exercising behavior. But what might we need to address to affect this change? So in other words, how do we get someone to change their eating behavior? How do we get them to start exercising? Well, let's think about the environment for a minute. We can ask them to park their car further away so they do a little more walking. We can ask them to walk instead of driving their car short distances. We can help them find a safe environment to exercise in. What about social factors? We also know that when we sit around a table with a lot of other people, we eat more than we do when we eat alone. Well, I certainly wouldn't discourage people from eating with other people, but maybe just being aware of that fact will help people. Cultural factors. We know that there are cultures that have traditions surrounding food, and that's very important. You can't change the culture, so how do you change their eating habit? And then psychological factors. I know that I cannot resist a piece of cheesecake. So for me, trying to convince me that I can't. I mean, I know I can't. I wish I could. So anyway, how am I going to get around that? Well, maybe what I need to change is I need to not order that piece of cheesecake. Or I need to have in my mind that if a piece of cheesecake is ordered to me, I'm going to refuse it. Because I know if it sits in front of me, I'm going to eat it. So we have to think about all the different things that might influence an individual in terms of their eating habits and their exercising habits. So I want to compare just for a minute a behavioral versus a medical intervention. So you can kind of see how similar they really are. So for both the behavior and the medical, you'll see that the statement of the problem is the same. We do a review of the literature to find out what do we know? What's the evidence base that something's going to be important? We choose a target population. Who's the population that's most going to benefit from this intervention? And then we choose a health outcome, and on the behavioral intervention, we also choose a behavior that's related to that outcome. And then on the medical side, we choose a medical method for our intervention. It might be medication, it might be a procedure, but it's a medical intervention of some sort. Whereas on the behavioral side, we're going to take a theoretical framework. We're going to use that framework and the evidence that we already know, and we're going to build an intervention. And we're going to come up with strategies and methods to try and change behavior. Then we're going to implement it. We're going to give the treatment, whether it's behavioral or medical, to the patients and the target population we've selected. And then after the intervention, we're going to evaluate it. So a couple things we're going to evaluate. We're going to evaluate our outcome, obviously, whatever outcome we were interested in. For the behavioral, we're going to also look at what the actual behavior was. Did it change? And in the medical model, for instance, if you gave medication, you might want to look at adherence. Did they take the pills as prescribed? And then the other thing we want to think about, like, so if you're doing a medical intervention, you know there's potential side effects, and you're going to try to measure those because you want to know what unintended consequences you might have from your intervention. We do the same thing with behavioral interventions. We also might want to look at what are some of the things that made a difference. So we might want to measure their self-efficacy for maybe exercising if it was an exercise intervention, or we might want to measure their outcome expectations to see if they thought this was worthwhile and see did that influence whether or not they had a change in their behavior and then a change in the outcome. So this is one for obesity, where we know that obesity is responsible for type 2 diabetes increase. We know from the literature that high-calorie diet and low exercise are risk factors for obesity. A target population that would be worth intervening with would be a target population that had a BMI or a body mass index over 30, which is considered obese. We would then choose our outcome to be BMI, in other words, reducing their BMI to be less than 30 or back into the overweight or normal weight categories. So our behavior here is going to be diet and exercise. Our medical intervention is going to be gastric bypass. We're going to use social cognitive theory to provide nutrition education, skills training for label reading, and maybe an exercise program that they could participate in, or exercise that they could do at home and self-monitor. That is, keep a diary of their exercise. For the gastric bypass, we're going to do surgery. At the end of the day, what we want to know is, did the patient lose weight? Their height's not going to change, so if they lost weight, they've reduced their BMI, or their body mass index. But we also want to know on the behavioral side, did they get more confident in making healthy food choices? Did they have a healthier diet as a result? And did they undertake more exercise? Did they have more confidence to undertake more exercise? And these are the kinds of things we measure. So we not only look at our outcome, but we also look at what things might have influenced our outcome. So one of the difficulties with behavior is, how do you measure it? So we have some hard health outcomes like BMI, like, we can look at accident rates. We can look at whether or not somebody with diabetes has lowered their HA1C level. So, but that's not always true for behaviors. Those are hard medical outcomes. But when we look at a behavior, there's a few behaviors that can be observed, like, is somebody actually wearing their seatbelt? Or we could, for smoking, test their cotinine to see if, in fact, we have a biological indication of whether or not they've been smoking. But most of the behaviors are self-reported. So you might guess that when you're asking somebody how often they exercise, they're going to tell you, because it's a good behavior, and if I tell you I exercise a lot, it makes me look like I'm a better person, I think. I might over-report my exercise a little bit. I might cheat, and instead of the 2 days a week I exercise, I might tell you 3, and instead of the 20 minutes a day I walk, I might tell you 30, because that's really what I mean to do. I don't always do it, but I mean to do it. So in my mind, that's good enough. Same thing with bad behaviors in reverse. If you ask me how often I ate potato chips or French fries, and I'm not really supposed to be eating them because I'm not supposed to be having a lot of salt, and I'm supposed to be reducing my caloric intake, especially my saturated fat intake, I would probably tell you that I wasn't eating it as often as I was, because I mean to eat it less. I really intend to eat it less than I do. So I would probably maybe cheat a little bit and tell you that I ate it less. So we know that self-reported behaviors aren't always the most reliable thing. We kind of take that with a grain of salt. We understand that. But we also want to assess what predicts or mediates that behavior. So, like, for instance, I mentioned self-efficacy or confidence. We know that for someone to do behavior, they have to think they can. If you told me that I needed to run a marathon tomorrow, I would tell you, okay, I'd walk out the door going, not a chance, because I know I can't. So before I could run that marathon, you would want to do something to build my self-efficacy, my confidence, that I could run it. And there's a lot of different things you could do. You could start by having me just run to the corner and back and build up my running every day so that I would build up my confidence that I, in fact, could do something. So we want to develop ways to measure that. Like you could just say to me, how confident are you that you could run a marathon? And I would say, well, it depends. You know, if there were a crazy animal chasing me, I have a lot more confidence than if I were doing it for fun. So we want to measure sort of my confidence in a lot of different circumstances. For instance, if I said, how sure are you that you can walk around the block? You'd say, no problem, I can do it. I can do it, no problem. Oh, can I do it when I don't feel well? Oh, maybe not. Can I do it when it's pouring down rain? Oh, definitely not. Can I do it when it's cold out? Not as likely. Or when it's real hot out? Not as likely. So there are a lot of different ways that we might want to ask it to really get a total picture of how confident someone is. And we use scales to do that. We call these psychosocial factors, like confidence is one, outcome expectations, whether or not I think something's going to happen when I do a certain behavior and how much I value that outcome. And we measure it that way. So we ask it a lot of different ways, and we kind of come up with a composite score, and it gives us a better idea of someone's psychosocial variables. So we look at that because it can predict or mediate the behavior change. So we also need to know, like if you do a medical intervention, if it's surgery, you know if it's done or not. You don't need to ask anybody. But if you're doing something like medication, like maybe a double-blind, placebo-controlled drug trial, well, I know that every time that patient comes in, you either ask them to bring their medicine and you do a pill count to see whether or not they took the number of pills they were supposed to, or you ask them to keep a diary. And what you're trying to do is assess, are they really getting the full intervention? Because if they're not getting the full intervention, then that's going to maybe make a difference on whether or not we get the outcome we're after. Well, we need to do the same thing. Well, with a behavioral study, sometimes it's a little bit harder because we can't count pills. We can do diaries, and that sort of helps us. But we actually are measuring whether there is fidelity to the intervention. Was it done as prescribed? We want to know to whom it was done and how much they got and who was engaged. So if we did, for instance, an entire room of people and we were going to have them exercise, we know that not everyone would exercise for the same length of time with the same intensity. So we'd want to measure that. We would call that our process data. In other words, how much of the exercise intervention did you get? And the reason we do that is because then we can account for that when we're looking at our outcomes. So somebody maybe who really didn't engage in an intervention, they didn't participate, they didn't keep their diaries, they didn't do whatever it was we asked, we would think that they probably will not have the same behavior change as somebody who really did it. And if our intervention worked, and we want to know if it worked, so we need to know who was engaged and who wasn't. The other thing we want to do is, just like if you're doing a drug study or another medical intervention, you want to know if there's side effects. So for instance, with gastric bypass, which is a great surgical intervention for people who are morbidly obese and cannot lose weight another way, one of the side effects is they really can't eat much at one time. So they've got to change their diet as a result. Well, if you didn't ask people after they had a gastric bypass right back in the beginning how it was going, you really wouldn't know if it made a difference. And you wouldn't know to tell people, this is a side effect you need to know or expect if you have this medical procedure. Well, we want to do the same thing, but for a little bit different reasons sometimes. We want to know what other things are happening because of this intervention. Are we having unintended consequences, which might be very good, or they might be not so good? But we want to know that. So we have to think about that up front. What are some of the things that could be an unintended consequence? And then how do we measure it? And we want to make sure we measure it up front. So I'm just going to give you a couple examples of a randomized controlled trial for STDs. So we wanted to, and I mentioned this study a little bit earlier and told you a little bit about it. So we wanted adolescent girls to not engage in unsafe sex. So we weren't promoting sex. These were all young women who were already sexually active. We had two conditions. We had a treatment condition and a control condition. And we randomly assigned them. It was like the flip of a coin. One went to the intervention, one went to the control. And so what we wanted to measure was what their sexual behaviors were like. In other words, did they have unprotected sex? Did they have sex with random partners or steady partners, protected, unprotected, and the frequency of it? We wanted to know how confident they were to negotiate safer sex. In other words, negotiate condom use or refusal to have unsafe sex. We wanted to increase their outcome expectations regarding safer sex, that they'd be healthier, that they would have a better life as a result. And then we wanted to overcome barriers to safer sex. And of course, our ultimate goal was to reduce sexually transmitted infections. So the treatment was skills building workshops. We wanted to build their skills. We taught them how to negotiate safer sex. We taught them arguments for it. We modeled them for them. We let them practice them. And then we talked about some of the barriers they faced and then kind of brainstormed ways to overcome them. Another study is an obesity study. It was a pre-post design. One condition, it was all overweight adults. They were assessed at a baseline where their BMI status, their height and weight, were measured. Their exercise and eating behaviors were noted. Their confidence in their ability to exercise on a regular basis, moderately, and make healthy eating choices were measured. Their motivation to control their weight, how important that was to them, was measured, and then their quality of life. And the treatment was an exercise program and nutrition class. And so the assessments we did at baseline, we did again at follow-up to see, was there a change? And if there was a change, where was the change? This is a community example. So we do have community interventions in public health research. It's usually a pre-post design, although sometimes you can compare it like one community to another, but you have to be very careful that the communities are matched, that they're very, very similar on a lot of important things, and then you also have to make sure that they're not so close together that they would influence each other. So a lot of times you just do a pre-post design. You do a baseline and follow-up, and so we were looking at tobacco use and from a random sample, and that was estimated from tobacco sales at random stores. And the treatment was indoor smoking bans and a media campaign, which consisted of billboards, point-of-purchase signage, radio and TV ads promoting no smoking. And so the same tobacco sales rate was measured again after this campaign to see if there was a change. So there are health behavior components in other forms of research. So no matter what kind of research you're doing, there are some components of health behavior that are a part of it. For instance, self-efficacy. If you have a patient who is not confident that they can remember to take pills 3 times a day, and that's what your study requires, or they're not confident that they can come to your office, or they're not sure that this is a good thing for them, they might not even sign up for your study. The pros and cons, decisional balance. When you're trying to recruit somebody to a research study, that's what you're doing. You're helping them decide, are the pros of being in this study and the cons of being in this study? So for instance, I'll get free medicine, but it might not really be the medicine. I'll get free blood work, oh, but they're going to stick me with a needle. So they're going to weigh all of those things, and that's a health behavior, is to decide the pros and cons of acting out in any certain way, including engaging in a study. And then their readiness. How ready are they to do what you're asking them to do? And of course, probably the most famous of all health behavior components to other research is the placebo effect. You have increased their outcome expectations that the pill they're taking is going to fix their problem. And so they will get a little bit better just from that expectation. So my main points here are that health behavior research is similar to other clinical research. Components of it are found in other clinical research, and that the principles of research are very similar across health behavior studies as well as medical studies. Thank you.